Hi everybody, Dr. Britt Talley Daniel MD, and I'm a neurologist and a headache doctor. Today I'll be podcasting on the subject of, is allodynia related to medication overuse headache? Well, allodynia is a word that means that touch hurts. The definition of allodynia is pain due to a stimulus that does not normally provoke pain. An example would be a light feather touch that should only produce touch sensation, but that would cause pain. Allodynia is different from hyperalgesia, which is an exaggerated response from a normally painful stimulus, although both can and often do coexist. Both are types of neuropathic pain. Inflammation surrounding the blood vessels in the brain during a migraine attack is involved. The nerve endings around the blood vessels send signals along the nerves to the central nervous system. This can result in the throbbing headache pain of a migraine. Acute pain treatment that works stops the signals coming in from the peripheral nerves. When these signals are not stopped, the spinal cord and brainstem nerves continue to send their own signals to maintain the pain of a migraine. Within as few as 1 or 2 hours of activity, they become free of what started them in the first place. They become sensitized or hyperexcitable. This is called central sensitization. Normally, touching the side of the head doesn't hurt, and the stimulus is perceived as touch only. Pushing a sharp pin into the head or touching the head with a hairdryer would activate pain and temperature fibers in the scalp and feel hot. If it got too hot, it would hurt and be painful. Allodynia is found with stage 4 of the migraine timing cycle with chronic migraine due to medication overuse headache. It's due to central sensitization because the central nervous system, the trigeminal nucleus, and the cutaneous scalp fibers are inflamed. After a sunburn, touch the involved area hurts. The touch fibers in the skin of the back and shoulders are inflamed by the burning of the sun. Wearing a shirt or a jacket over a sunburned shoulder or arm would be perceived as painful, not just as touch. Touch of one side of the head during a migraine may also hurt, as the pain sensory fibers are activated. Activities that may cause pain with allodynia are combing or brushing the hair, wearing a hat, earrings, a necklace, glasses, or lying in bed on the involved side of the head. All of these touch activities may hurt in a patient who has allodynia related to medication overuse headache. So is allodynia related to medication overuse headache? Yes, it occurs in 3 to 4% of patients with migraine. In the first edition of the International Classification of Headache Disorders 1, published in 1980, this overtreatment syndrome was called rebound headache. This was because the usual clinical situation with a headache patient would be that a patient with migraine would complain of a severe, usually early morning headache. They would take their painkiller, say like butalbital or hydrocodone, and the headache would go away, only to return hours later worse than before. The headache had rebounded, much like a rebound in basketball. The frequency of migraine could be referred to as episodic or chronic. According to the International Classification of Headaches number 3, published in 2018, episodic migraine is 14 or less migraine headaches a week, while chronic migraine is defined as 15 or more headaches per month, 8 of which have migraine features. The migraine features here mean severe on one side, throbbing, disabling, headache with nausea, vomiting, and sensitivity to light and sound. Chronic migraine is 3 to 4% of all headache, and 80 to 90% of patients with chronic migraine have medication overuse headache. Therefore, chronic migraine and medication overuse headache are commonly associated together, period. Also, 80 to 90% of persons at a headache clinic have chronic migraine related to medication overuse headache. Related questions. What is the migraine timing cycle? There are 4 steps in the migraine process, which I like to call the migraine timing cycle. The first step is trigeminal inflammation by the brainstem. Second step, at 20 to 40 minutes, the ganglia, the nerve, and the artery of the brain start to release the inflammatory neuropeptides, neurokinin A, substance P, and CGRP. The third step occurs about 2 hours into the headache. If a headache starts at 8, we're talking about 10 o'clock. as the release of the chemical causes meningeal artery vasodilatation. And then the fourth steps at 11 or 12 o'clock, or 3 to 4 hours into the headache, the neurochemicals cause inflammation of the thalamus. The thalamus is a deep nucleus in the center of the brain, which is called the pain center of the brain. This fourth step is also called central sensitization because steps 1, 2, and 3 occur in the skull but are outside the brain. So the trigeminal nerve, the nerve ganglion, and the arterial ganglions and the cerebral arteries are in the skull, but they're not part of the brain. But step 4, involving the central nervous system, inflames the thalamus, which is a deep brain nucleus. So stage 4 of the migraine cycle is when allodynia occurs. Why is migraine defined as lasting 4 to 72 hours? Migraine is defined by the International Classification of Headache as lasting 4 to 72 hours, and this is done not for some trivial, abstract academic reason, using 3 days or 72 hours as the time a migraine may last, but rather because that's how long these inflammatory neuropeptides stay in the body. Research studies have been performed wherein a doctor would start a migraine in a research subject by injecting the vasodilator nitrate. In an hour, it increased the inflammatory neurochemicals was found by collecting blood from the jugular vein as it drained down to the brain to the liver, and then is discharged in the toilet after 3 days. And these inflammatory chemicals could be found for 3 days. What causes the development of medication of his headache? If one treats migraine with over-the-counter drugs like Advil or Tylenol, they don't stop the release of neuropeptides and the inflammation, yet triptans will block the release of the inflammatory neuropeptides. And that's why they are such important and effective drugs for treating migraines. But to be effective, triptans have to be used at the start of the headache cycle or within 24 minutes of the start of the migraine. Are there no-no drugs for treating migraine? Triptans are contraindicated for patients with coronary disease or uncontrolled hypertension and cannot be used in these patients. So some of these patients may respond to butalbital or an opioid narcotic like tramadol or hydrocodone. But these class 4 narcotic drugs must be controlled by the doctor and used very rarely, and they are really no-no drugs. And now we have a new group of drugs called the G-Pents, which can be used in this situation. Also, 80% of patients respond to triptans, but 20% do not, and they may need something else like DHE injection or nasal spray or timolol eye drops in that situation to treat the headache. And migraine patients should be treated with triptans, but never with opiate drugs or drugs like butalbital or Fioricet. Butalbital is a barbiturate drug. It is, in my opinion, the worst drug in the world that causes medication overuse headache. It's been banned in every country in the world except in Canada and the United States because it causes medication overuse headache. The use of butalbital in America is a political issue to be resolved with legislatures, and so far neurologists and headache doctors have not been successful getting legislators to eliminate the use of it. What about treating migraine with over-the-counter drugs? Caffeine, Tylenol, Advil, Aleve, and triptans can cause medication overuse headache if too many of these drugs are taken over a period of time. And the general rule of migraine patients to prevent medication overuse headache is to limit over-the-counter painkillers and triptans to no more than 2 days a week. What happens if over-the-counters, butalbital, opiates, or triptans are used more than 2 days a week? Well, that gets into what's called medication overuse headache. It's the current term for persons who have chronic migraine from overuse of medication. That used to be called rebound headache, but that's an old term. If the patient uses the over-the-counter medications or a triptan, a transition occurs. So after several migraines had occurred within a week or two, every time the patient takes caffeine or Tylenol or a triptan, the inflammatory neurochemicals are released and they stay in the body for 3 days, and so the migraine process becomes continuous. It's sort of like putting lighter fluid on a fire, which makes the fire continue to burn. If one considers that migraine can generate chemicals that last 3 days and multiply that by 2 days, the result may be 6 days of neurochemical release per week. So if the doctor allowed his patients to take Tylenol or triptan 3 days a week, that's 9 days of chemical inflammation, more than 7 days in a week, and explains the limitation of all painkillers and triptans to no more than 2 days a week. Is there a more thorough discussion in the migraine timing cycle? Yes, go to my webpage at drmigraine.com. However, this timing cycle points the reason why migraine should be treated early with a triptan. The patient only has 20 to 40 minutes after the onset of headache pain before the chemicals are released, and a triptan drug will block the release of these chemicals. It's just that simple. Most patients don't know to treat early, and therefore the chemicals that are released inflame the trigeminal nerve, the arteries, and the thalamus. The patient returns and states to the doctor, triptan doesn't work. It's reported that triptans will help migraine headache anytime during a migraine, even if treated late, but using migraine useless unless migraine is treated at onset. The patient will not be headache-free within 2 hours. And headache-free here means that all migraine symptoms are gone. Headache, nausea, sound sensitivity, light sensitivity, olfactory sensitivity, mental cloudiness. In my office, I go over and over again at this point with patients to treat early, and then the next time they come in, many of them report that they did well with the triptan and the migraine was gone early. Many patients tell me that they can get released within 15 to 20 minutes, which is less than the reported time it takes the drug to work. How is medication-induced headache treated? Treatment here is it means you have to stop the painkillers, the NSAIDs, caffeine, triptans, barbiturate, or opiates. This can be done all at once, or the drugs may be tapered off slowly. The patient should do the migraine lifestyle, might consider starting a daily preventive drug, probably take 1 or 2 weeks of prednisone or Medrol dose pack to decrease inflammation of the headache, and then use DHE, timolol, or olanzapine for acute headache pain management until the frequent headaches backs off. So these are my thoughts on is Allodynia related to medication-induced headache? Please click on subscribe down there so we can follow each other. God bless all you persons who have migraine, and I will see you on the next talk.